Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody. Welcome to Airway Answers. We are definitely in this together. I see a lot of social media posts, my patients, people with questions about the mandible. Can the mandible be expanded? And I have an amazing airway-focused orthodontist here today, Dr. Yousefian, and he is in Bellevue, Washington. And I've known you for a while now. We both are on the CAS, the Children's Airway Screener Task Force team through the ADA. So around the time of COVID, we had been meeting online with a whole group of people developing this universal screening tool that dentists will use to screen children for sleep apnea. So I've known you for many, many years. And I know Ron Eade from Jaw Hacks has interviewed you quite a few times, and I've watched a bunch of those interviews, and he described you as the man with the plan for the mandible. That's what Ron said, the man with the plan for the mandible. And I love this. I'm like, that's perfect quote. So I'm going to review your bio, and we're going to talk about all the different approaches you use and your thoughts on mandibular expansion and how that fits in the protocol for our orthodontic and airway patients. So Dr. Yousefian is a board-certified orthodontist based in Bellevue, Washington, known for his specialized work in airway-focused orthodontics and dental sleep medicine. He provides comprehensive dental treatment for children, teens, and adults, so you work with a variety of ages. Dr. Yousefian is also known for pioneering a treatment methodology called Telodontics, and this is something we're going to talk about today. We're going to go over all about Telodontics and Telegnathics and what that is. Dr. Yousefian treats a wide array of complex issues such as TMJ-related jaw pain and headaches, bite problems, snoring and sleep apnea. And also, Dr. Yousefian began formal education at Washington University in St. Louis and received a degree of dentistry in 1987. By 1991, he had completed his postgraduate training in orthodontics at Ohio State University in Columbus, earning a Master of Science in Biology and another in Physical Anthropology, which is really fascinating. So I have questions for you about that as well and how that relates to the work you do. Dr. Yousefian has served in many areas of academic teaching and consulting and has been involved in numerous research projects. He travels both nationally and internationally to deliver lectures to universities, dental and medical societies, study clubs, and has contributed to more than 30 publications and articles in scientific journals and textbooks. And in fact, just this year in April 2025, you just published a book. What is the title of the book you just published?
Pediatric treatment of sleep apnea with Telodontics, Telegnathics.
I don't know how you find time to do all these amazing things, but that's how you airway people are. You are so amazing just educating the public because we know we're saving lives in this work that we're doing. This is a healthcare crisis, and the work of treating airway and sleep has such a profound impact on the overall health of every person who is benefiting from such treatment. So thank you for all the time and the work you do in spreading this message. Dr. Yousefian is also a diplomate of the American Board of Orthodontics and the American Board of Dental Sleep Medicine and has won numerous awards, including the American Association of Orthodontists Award of Special Merit. Dr. Yousefian is passionate about developing and advancing the art of orthodontics to offer the best prevention and treatment available. He is acclaimed for leading-edge prevention diagnostic treatment methods for TMD, OSA, and Telodontics, and we're going to really get into that aspect today. So what I want to start off first is thanking you for your time. I know you're busy in your schedule, treating all of your patients, writing all these books and publications and lecturing. So thank you so much for being here, Doctor.
Of course, my pleasure. Thank you for inviting me to talk about this.
Of course. Thanks for spreading this message. And I really am curious how you decided to become an orthodontist in the first place. And then what led you to specialize in this airway orthodontic approach and learning about sleep and airway? Was there an aha moment or something that happened in your life that brought this to your attention, maybe you were traditional focus tooth alignment orthodontist and then shift to Airway. So can you tell me all about that?
So, Nicole, let me share the screen.
So people know if they're listening to this on a podcast, go over to YouTube because you are going to be sharing a lot of important visuals for us. Okay.
Yeah, this is the answer to your question. How did, the whole area of the orthodontics, I got, involved with orthodontics because, well, when I was growing up, I was very, very, interested, and I was good at working with my hand and thinking, and always I thought I was thinking about getting to medicine, saving lives, always was in my mind. But when I got closer and closer to pick my, area of the, when I was going to go to college, pick the area of medicine, what I'm going to do, they told me that, well, dentists, they work with their hands and their brain, and medical doctors are very, very good with their brain and, work with the hands. So making jewelry, my sister, when I was growing up, making things with my hand. So I decided, what, I'm so good with my handwork and doing things and creating things. So I decided to go to dentistry. And then later, just I was fascinated with this science of moving teeth and changing the faces, and became interested into going to orthodontics. But one thing that changed my life and the way that I look at the science of orthodontics is sitting in this picture. Patients like this, that they were coming to my practice, and they were babies, and then of course they grow up, and I show you the future of this kid, that how it kind of changed the way that I was looking at the area of orthodontics, and changed this to the new paradigm that is called teledontics and telegnathics. So if we look at the book, well, thank you very much for mentioning. Finally, Nicole, after 7 years, the book is published, and of course with the help of significant number, 36 other contributors that they are coming from different academic backgrounds. Now we are proud to mention that we have the contributors from Harvard, from Stanford, from John Hopkins University, and the concept was recognized by John Hopkins, what we call educators. They recognized the term teledontics, and they advocated as a new paradigm shift in the field of dentistry and medicine, that bridging the gap between dentistry and medicine. Well, the book, it is dedicated to Dr. Gimino, my mentor. He's the one that also has instrumental impact on how I look at the orthodontics, and came up with this paradigm shift of the teledontics. But at the same time, unfortunately, he started contributing to the book, but in the middle of the writing the chapter, he passed away. There are 36, as I mentioned to you, contributors to the first volume, but the second volume is going to be another 50 additional different contributors to the second volume. That more, the first volume is focusing on up to age 33, but then the second volume is going to be age 30 to 97. So now that was my probably the a little bit of introduction. Why the concept of teledontics? So the concept of the teledontics is, orthodontics, Nicole, is by far one of the most sophisticated science in dentistry and medicine. The science of moving teeth and manipulating the way the jaws grow. And again, today we know that is one of the most powerful area of dentistry and medicine that can treat, and manage the upper airway of the patient. But not all part of the science, unfortunately, has been used properly. So based on the traditional science of orthodontic, that it was just straight teeth, there are cases that, like what you see right now on the screen, that unfortunately, when patient had malocclusion and bite was not right, so the traditional orthodontics say that focus on the bite. So part of the things that they use is a headgear. And this is something that developed later in 1800s and late, 1900, and helped the clinicians to correct the bite. Well, at the time, the area of the airway was not focused as much as today is focused on. As a result of that, some of these concept of orthodontic became popular, using headgear, or in this case, you see extraction, moving the upper teeth, or moving the upper jaw, or holding the growth of the upper jaw impeded, or pushing the upper jaw to lower jaw to get the bite right. Well, unfortunately, that is something that focused on making the teeth straight. But when it came to the area of the airway, you see that airway of the patient is like a straw. How this patient is going to breathe through this? Well, it is not the fault of the orthodontics, is they understand the concept and missing the importance of the relationship of the jaw, supporting a structure for airway, and when we move them back, how it's going to compromise the airway, sleep, and systemic health of the patient. So the teledontics is called non-restrictive orthodontics treatment, meaning that it is part of the technology, is part of the technique, is the different technique of orthodontics, but is the purification of the science and instrumentation, meaning that all instrumentation, all the vocabulary, all new nomenclature is toward expansion, advancement of the jaws, teeth away from the base of the skull, so support the airway of this patient better. So it means that in teledontics, you do not extract the way that the teeth are going to move back. You do not even extract the lower teeth and constrict in the lower arch. You don't slenderize significantly because it can kind of constrict the lower arch. You don't set the lower jaw back surgically because that can compromise the airway. And in compromised airway on the patient that they're susceptible, not all, that can make them vulnerable to develop airway issues and maybe develop sleep apnea. So in this case, if we look at how we resume this, we gave the patient something that on the temporary basis, when he wears every night, is going to support his airway. APNO TX and APNO Dent is the oral appliance. It is the FDA cleared oral appliance. It can be used in conjunction with Invisalign, braces, expanders, surgical wires, and is for the temporomandibular joint, what we call stabilization, pain management, managing the sleep apnea, snoring, and children, helping to grow the jaw, and is part of the teledontics technology. So in this case, what we did for this patient, we stabilized the joint. The joints, they were so badly damaged that if we look at what we call the damage to the left side, the condyles, he had the stage of osteoarthritis, and they were talk about doing the total joint replacement for this patient because the structure of the condyles, which is supporting the lower jaw, was so compromised, and the clinician, surgeon, orthodontist, that they were on the what we called edge of this orthodontic science and orthognathic, they were thinking about doing the total joint replacement. But with the help of the APNO TX, we stabilized the joint of the patient now can breathe. And in stage one, we expanded his jaw, stage one surgery. And in stage two, 6 months later, we brought the jaws forward surgically. Now, one thing, Nicole, when we were working on this patient and the surgeon wanted to get him qualified for insurance reimbursement, even with this compromised face that you notice in the beginning, and I showed you, the insurance company would not pay for the orthognathic surgery because consider it cosmetic, the bite is fine, patient is fine. Why do you want to spend money and surgery to, it's just a cosmetic surgery? But something changed the paradigm, and that is proving the patient has sleep apnea. The term telegnathic surgery now is validated by American Association of Orthodontics in their 2019 white paper as the most effective surgery, which works by bringing the upper and lower jaw forward. Maxillomandibular advancement surgery is called MMA surgery as the most effective surgery for treatment of sleep apnea. So in 2019, this was published in a white paper by American Association of Orthodontics. In 2019, also, American Academy of Sleep Medicine published a book that also validated the telegnathic surgery also is one of the most effective surgical means for treatment of sleep apnea. So the surgeon, when he was doing the pre-authorization for this case, submitted the airway sleep apnea that showed that he has moderate sleep apnea, not very severe, but above 15. Guess what? The medical insurance approved the MMA or maxillomandibular advancement surgery to treat this case. So the out-of-pocket for this patient that now went through the surgery, and with that surgery, both upper and lower jaw was advanced by the help of great surgeon, Dr. Samuel Bobak, that he practices in Seattle, Washington. And this is, he used the inverted L type of MMA surgery, and he was able, without any total joint replacement, which is too early for this age, and bring the jaws forward and brought the chin forward, which is again as part of the telegnathic surgery. And by doing this surgery, significantly enhanced not only the facial profile of the patient and make patient normalize back to facial profile that was supposed to be there if the jaws they didn't get damaged, if orthodontically their jaws and teeth they were not pushed back, and also if you look at the airway of the patient, how much enhanced the upper airway of the patient that resolve the sleep apnea and cure the sleep apnea. That's the difference between orthodontics, which becomes sometimes, if we use it improperly, can actually deteriorate the facial profile, deteriorate the airway, and can introduce and make the patient vulnerable for diseases and comorbidities that comes with airway discrepancy. And orthodontics, that is just cosmetic. Orthognathic surgery is just cosmetic surgery. When we change to telodontics and telegnathics, it fill up the gap between misunderstanding of dentistry and medicine and bring a new paradigm shift, bringing the jaws forward, not just for aesthetic, but enhancing the airway, improving the sleep apnea, and prevention of the comorbidities, high blood pressure, high cholesterol, metabolic syndrome, learning disability, heart attack, stroke, cancer. And hopefully that is going to describe the difference between
Wow.
orthodontics and telegnathics.
Yes, and that face, that young man's face changed so significantly, almost like he probably got his life back. Because I wonder all of the issues he was having with such retruded lower jaw, but both jaws so far back. I'd love to hear the history too on early feeding, breastfeeding, tongue tie. I'm really curious, but I want to step back. Telodontics and telegnathics. So I just want to summarize, make sure I have this correct. So those concepts are going to differ from orthodontics and orthognathics because orthodontics and orthognathics are focusing on straightening teeth and jaws, whereas telodontics and telegnathics are non-restrictive or non-retractive orthodontic techniques. So we're thinking of the almost like what we'd say airway focused orthodontics or airway focused, attending to the jaw. So we're not looking solely at the cosmetic alignment of the teeth, but we're wanting to keep everything forward and wide for better breathing, right? Is that a good summary
Right?
also?
You describe it. The great summary. Yes.
So I found on your website, this is also another thing about teledontics. It's the permanent airway solution. We say the science of teledontics offers exceptional non-surgical treatment options that can prevent, properly manage, and treat OSA in children and adults. That's something you had written. Orthodontics may fall short because traditional orthodontic and orthognathics still have their place in the treatment of crooked teeth, jaws, and TMJ discrepancies. Yet until recently, they failed to recognize the relationship between the upper airway, oral cavity, facial structures, and its physiologic importance for systemic health. Practitioners were unaware that by retracting teeth, setting jaws back, or extracting a few teeth here and there in order to make room for crowding teeth could directly impact the patient's airway in a negative manner. And that's exactly where teledontics steps in. The science of teledontics in support with telegnathics, so the tooth aspect and the jaw aspect, begins with the identification of the physiologic importance of the pharyngo, oral, facial anatomy in the human body. So you call that POF. The POF has evolved to carry out the important life-sustaining functions such as breathing, chewing, swallowing, speech, facial expressions. And this science is the first to recognize the negative effect of the POF, of any discrepancies in that realm on systemic health, right? That's what we're all interested when we're in this airway field. We recognize that poor breathing, poor jaw growth leads to or can lead to poor sleep quality, which can impact every single aspect of our body, emotional and physical well-being. So this can be directly impacted by oral cavity facial structures. So what we're talking about teledontics and telegnathics, we're directly thinking about that aspect, that airway component. And I'm curious, these words, teledontics and telegnathics, when did those concepts come about? And are those words things that all orthodontists know and understand? Did you invent that? I'm not sure.
Sure.
Teach us.
Well, the thing is that the word telegnatics has been around for a long time. Orthodontics meaning straight teeth, Greek name straight teeth, orthognathic straight jaws. But the term telegnatics, meaning that moving the jaws to distance, tele for improvement of the airway. So if you're talking about orthodontics and orthognathic, straight jaws, straight teeth, telegnatic meaning that moving the jaws to distance to correct it needs to have a synonymous thing that comparable things. So the term teledontics gradually was invented, polished, and what we call it was validated by the scientists and researchers from the John Hopkins University as the terminology that describes orthodontics versus as a maybe sometimes restrictive modality to non-restrictive modality. So the teledontics has been developed to complement telegnathic surgery and the term telegnathics.
So are those terms taught in orthodontic schools? And if I were to go to an orthodontist in my area, would they look at me like, what are you talking about? Or is that a universally known concept?
They're going to say that, what are you talking about? But the thing is that
Okay.
the telegnatics has been there for a long time. Now the concept of teledontic is joining that, complementing the idea. But remember, Nicole, the paradigm shift is the same as if you heard or you're aware of the term blue baby syndrome. Blue baby syndrome is the concept that babies that they have hole between their left and right ventricle of the heart, this population of patients, they were dying early in childhood because of the mixture of the dark and oxygenated blood. For a long time in 1800, doing the heart surgery was forbidden. So no surgeon was allowed to do the heart surgery. John Hopkins University came and changed the paradigm by doing the first heart surgery in late 1800 or early 1900. And that paradigm shift now is saving billions of lives or millions of lives every day and every year. So the concept of the teledontics is the new paradigm shift. Telodontics, telegnathics, although is not taught at universities right now, but the book is out and people they talk about it. So before we started this podcast and interview, just two of the famous dedicated people in the area of Airway, Mrs. Candy and Mr. Brad Sparks, founders of CAF, which is the Children Airway First Foundation. They were here talking about it because they heard about the concept of these telodontics and telegnathics and the book, and they valued how important it is for saving lives and improving the airway of these children. So it is a new concept. You know, Nicole, is the same concept as if I talk to you about artificial intelligence, AI. How surprised you were about a year ago hearing about the AI. AI is part of our life. Every day we are dealing with it. So we
Yeah.
need to accept it. It's a paradigm shift that is coming and bridging the gap between medicine and dentistry.
I like that. And I like that confidence. And yes, AI, Chat GPT is my best friend. I talk to him daily. So, yeah, this concept. So, what I'm hearing also is this concept goes along with the thought that retracting or extracting teeth impacts the airway. And we have orthodontists who are saying that there is no impact on the airway with retractions and extractions. So, what would you say to other orthodontists who are thinking along those lines or commenting like that?
You know, actually, based on the research was done in San Antonio several years ago, they look at the population of 10,000, I believe, or something in that category, 5 to 10,000 patients that they have extraction. They look at their airway, not necessarily sleep and sleep apnea, and they notice that, well, the extraction really does not mean that every case that is extracted, they are going to have airway issues. But now let's go back to that. If you can show the case that we were reviewing. So extraction, not every extraction has the same impact. So we call it maximum anchorage. Nicole, if the teeth are extracted, for example, first bicuspid extracted like this case, and the what we call the front teeth are pushed back to the point that is going to push the tongue back to the airway, yes, that type of extraction is going to be kind of effective on constricting the airway. But if you extract, for example, second bicuspid, and somehow you have a mechanism to bring the molars forward without retracting the anterior teeth back, maybe that is not what we call constrictive orthodontic approach. So not every extraction or every type of extraction or every mechanic that you use for extraction is going to compromise the airway, but we need to be careful. Avoid the type of extraction systems and mechanics that is going to push the teeth backward, trapping the tongue into the airway. That's what the problem is.
That's perfect. That's exactly what we think. And this is just coming to my brain right now. How is this concept different than orthotropics? Because it seems like a similar idea.
So, do you know what? I'm glad, Nicole, you mentioned that. The terms like orthotropic, forward or forwardodontics that is used, or orthotropic that Dr. Mew initiated and originated, the idea. All these are demand for the new paradigm shift. So when Dr. Mew developed the orthotropic concept, well, the concept is that describing a science that is not going to push the teeth back. And he called it orthotropic. It is working, but it is trying again, or when the term non-retractive orthodontic is mentioned, or again I mentioned to you forwardodontics. All this concept again is the need or describing the need for the science understanding that doesn't move the teeth and jaws backward and opening and enhancing the growth of the jaws and opening the airway. Now, orthotropic as another system, and it has its own valuable concepts for a period of time when we had the limited, what we call limited understanding understanding, came. Orthotropic, when it came at the time that they was talking about teeth, they were talking about face. There was no concept of the airway at the time. I don't recall, and please, somebody out there educate me. When orthotropic was mentioned for the first time, there was no concept of the airway. And then the paradigm shift in the airway and sleep brought there to the attention that yes, orthotropic, not pushing the teeth back, maybe has some influence on not distracting the airway and damaging the airway, but orthotropic was not developed just treating sleep apnea. The concept of telodontics and telegnathics is the new paradigm shift that is synonymous. It equal to airway and treatment of sleep apnea. That's why there is a little bit of shift, but when we go to origin of the demand for change of paradigm, they come from the same concept. Don't push the teeth back. Don't retract the jaws back.
Okay. And that leads me to a question that I wasn't going to address until the end, but it actually makes me think right now. I saw in a Facebook post, a parent was saying, oh, my child went to I think it was an airway focused dentist. And they said the palate was very narrow. And I don't remember the age. Maybe the child was about 7. So they wanted to do expansion. And the parent said, but the child has no issues, no sleep issues, no breathing issues, doesn't snore. So why would we do that? Why would we pay for that? So I wanted to ask your opinion. Would you ever say it's important to address skeletal deficiencies with the thought of prevention of future issues? Or how does that fit into this paradigm?
Well, the thing is that now every kid goes to the orthodontist and get expansion. Is that it is something that is just newly was introduced and kind of challenge in the field of orthodontics. Actually, there was a recent publication in the AJO, American Journal of Dentofacial Orthopedics, by American that published that challenged that idea. Is it right that now every kid goes to the orthodontist, they get airway focus, expand the jaws? Is that a right treatment? If everybody needs to go, get expanded? Well, the question is that we need to look at when we look at that specific case of the child growing up, and the orthodontist saying that we need to expand the palate because the palate is narrow, and they say, well, my kid doesn't have any airway issues, why should I expand the palate? Couple of things. First of all, by knowing somebody is called Jerry Simmons. Jerry, he has and you were tested by this system. Nicole, I remember in your background, if you don't mind, because I know that you with Ron and interviewing at JawHacks, you mentioned that they miss your sleep apnea. You were tired, you were clinching, grinding, but at the same time, they could not diagnose you with sleep apnea. All right? Till
Exactly.
somebody with the knowledge of Jerry Simmons put you in the, during your sleep, send you something is called piss through your nose, sitting in the throat. Very precisely and scientifically, they diagnose you that when you breathe in, the negative pressure goes up, you wake up, you stiffen or tone your airway so the airway doesn't collapse, but at the same time you arouse to the lighter part of the sleep. That's why makes you tired, that's why you clinch and grind. Well, that's the same thing. When they did the sleep apnea, or the kid does not snore, because snoring, we know that is the first sign of the sleep apnea in children, 95%, and adults, 75%. If the child snores, 95% has a sleep apnea. If the adult snores, 75%. But if the child does not snore or adult does not snore, doesn't mean that they have a sleep apnea. It's a silence sleep apnea, meaning that they have the event, but nothing makes noise or make and attention to presence of the disease. So there is a chance that this kid is misdiagnosed. All right. But at the same time, we are not treating the kid for the next 2 years, 5 years, 10 years. We are treating these kids for up to age 100, because now we know human biology, the way that it is, and how much the medical is advanced. They they can reach to age 120 or 125 or beyond that. Is that constricted mouth, is it good enough to support the tongue and support the airway for the rest of the life of that kid? That's the question. That's why that orthodontist that trained to use headgear before, trained to be kind of indifferent to the size of the jaw or arch and width, now they're alert. They know that the paradigm shift, that evolution is changing the human face of humanity and make them constricted. If we give them a little bit heads up or a little bit of help and a little bit push to make it a little bit wider, because we know the growth is up to age 20, meaning that teeth, jaws, they grow up to age 20 and they stop. So if that kid grows up to age 20, growth is a stop. But then, Nicole, guess what is keep growing for the rest of life? Tongue. Tongue is going to keep growing. And then accumulation of fatty tissue, gaining weight, make the tongue bigger. So that tongue that is not a problem and is not creating a sleep apnea now, maybe in 10 years or 20 years or 30 years, when that kid becomes adult that maybe is a little bit overweight, that tongue is becoming problem. So that orthodontist, knowingly or not knowingly, is doing some big favor to that kid by expanding the jaw instead of being indifferent to it or wants to do something that is restrictive. So that's my answer and
Yeah,
description.
that's exactly. And many times signs appear before symptoms are present, and we want to optimize normal anatomy, normalize anatomy, right? Optimize that. And I think that's a really good point. You said the treatment we do, will that support that person for the rest of their life? And that's a really good thought and a way to think about it is, yeah, the body changes and typically things don't get better as we age. Like you said, we gain weight, muscle tone goes down. Just basic aging causes muscle tone to drop, tissue elasticity, things like that. So I do think it's important to attend to these issues at a young age, even if there are not symptoms. And also, you said that child might be misdiagnosed. They might not have had correct diagnostic methods. The mom might think the child's fine, but there might be some subtle underlying issues. And there's also research showing that males around the time of puberty will have a relapse of sleep apnea if they did have it at a younger age and it was treated and cured via palatal expansion and tonsil and adenoid removal. A huge percentage of them will actually have a relapse around puberty because of the growth of the tongue. So I do think it's important, if there are no symptoms, we still want to optimize the anatomy. So that's a really good way to address that. And I was thinking along the same lines as you. So now I want to get into the mandible, because this is the question, like Ron said, Ron from Jaw Hacks, you are the man with the plan about the mandible. So let's talk about this. Before we kind of get into the details about mandibular expansion, can you just talk about the different ways of expanding the upper and lower jaws to treat airway issues like MARPE, SARPE, MMA, dental tipping or uprighting, and also address what is DAME and MSDO? So I know there's a lot going on in that question, and I can help break it down because I said too many things. So could you talk about just general expansion for airway purposes? Then we'll get into the mandible.
Sure. So the thing is that let's start with the idea of expansion, rapid palatal expansion. So orthodontists, they realize that by look at the anatomy and experiment, they notice that if the upper jaw, if there are enough force applied to teeth, at the time 150 years ago, they didn't have fancy pins or screws to put on the roof of the mouth. So they started putting the expanders on the teeth and then opening these jack screws that open and use the teeth as anchorage to expand the upper jaw. And they noticed that when they do that, the mid-palatal suture is going to open up to age 12, 13, and then now realize that also as a result of that, not only the palate gets wider, the other side of it, the nasal cavity, and maybe is getting wider. So they have been using this for kids for a long, long time. We call it rapid palatal expansion. It was very useful using the teeth as anchorage, grabbing two pieces of maxilla and expand it apart and make the palate wider, mouth wider, which is great for the tongue, improving the airway and nasal cavity. But then they noticed that in adult population, females still they respond to it because the structure of the mid-palatal suture is easier to break away. The ossification is not as hard as the males. Males, they take a little bit more force and then they mature faster at age 17, 18, sometimes 19. Above is very hard to break it away. So then they came up with the concept of SARPI, surgically assisted rapid palatal expansion. For years, maybe 100 years, 50 years to 100 years, they were doing these surgeries, creating cut on the buccal areas above the roots of posterior teeth, make the area of resistance to expansion release, and then make the mid-palatal cut and then expanding. We call it surgically assisted rapid palatal expansion. And that was for a long, long time working. But then the new innovation came and developed this technology that is called MARPI, microimplant assisted rapid palatal expansion. So it means that, all right, in the population of adults that now we think that the mid-palatal suture is more resistant to expansion, we secure the expander to the palate of the patient. With the screws, now we are going to grab the half of the maxilla in conjunction with the teeth. Now we have more anchorage to grab the bone and expand. Dr. Moon is one of the scientists that came up with the idea of the MARPI, microimplant assisted rapid palatal expansion, and it worked. Significant number of patients, they responded. They recognized that up to age 71, a female patient or individual, it was expanding the palate of that individual with no surgery. But it doesn't work on everybody. So then they started thinking about that, okay, MARPI, putting screws and expanding. But then the problem is that if the expansion is not symmetric and the resistance is not equal on both sides, maybe there are zygomatic area and the malar area of the upper jaw, sometimes one side expands and one side doesn't expand. So as a result of that, clinician Dr. Liu at Stanford University, they came up with the new idea. So reducing the complexity of expansion and making it more predictable, not expanding one side or becoming asymmetric. So they used part of the idea of SARPI, which is surgically assisted cuts above the roots of the posterior teeth. They put what we call TADs or microimplants on the roof of the mouth, but at the same time, they introduced the cuts to this area and they reduced the complexity of asymmetric or nasal bone is going to get what we call dislocated or zygomatic bone gets this. So as a result of that, when surgeon and orthodontist came together and started working on this, they had successful stories to say expanding the palate and nasal cavity. So that was the evolution of the science, MARPI, and then the concept of dome, distraction, osteogenesis, maxillary expansion. Dome came along, initiated, as I believe, from Stanford University, very successfully and predictably can do this. But at the same time, this was the science that was developed and worked with orthodontists and surgeon working together. The area of the airway orthodontics is the good concept, Nicole. But opening the airway doesn't mean that you treat a sleep apnea, right? A sleep apnea is different animal. It is the combination of medical issues, physiological issues, and anatomical issues, all right? Airway orthodontic is good because the concept meaning that now instead of ignoring the size of the jaws and nasal cavity, extracting or doing constrictive works, we come and expand. Now, orthodontists, they realize that with the concept of expansion or MARPI, putting screws on the roof of the mouth, can expand. But this is an area of interdisciplinary, this is a multifactorial problem and needs interdisciplinary approach. So it means that if, as an orthodontist, I come and become as a hammer, they're looking at everything as a nail. Yeah, I can expand everybody in my orthodontic office, putting the screws on the roof of the mouth and just force them to open. They know, clinicians, they know that they are not equal responsive on every single individual. And we get it here. We get cases that one side zygoma pushed out, or the mandible or maxilla is asymmetrically expanded, or this nasal bone got distracted because of too much force, unequal force that made the asymmetric. Again, I'm emphasizing this is in a multifactorial problem and requires interdisciplinary. Based on my experience in my hand as orthodontist, when I work with my surgeon or periodontist, and he helped me to cut the bone in the middle or the palate and is predictably remove the resistance from two halves of the maxilla to expand, it was more predictable symmetrical expansion. And also nasal cavity, as long as we don't extend the cuts inside the nasal cavity, still the walls of the nasal cavity can be expanded out, and nasal cavity in the upper part of the nasal cavity and lower part expands and is going to improve the airway. So that has been the evolution, and there are a lot of techniques. Another technique, mind, a minimally invasive maxillary expansion. Those are the terms that are good terms, but that has been evolution of MARPI. But that doesn't mean that we need to ignore what we have been using. SARPI has been used for a long time. We didn't use MARPI to put screws on the roof of the mouth. Now, the other concept that we remove the arms of the expanders and just go to the palate and put the screws is a little bit of what we call saying that the new technology and the new mechanism is replacing the old. We need to use the old one that was working for us for a long time and incorporating the new technology. Now, and again, the issue of the airway orthodontic. In my office, or clinicians that they are doing what I'm doing, we are treating a sleep apnea, right? You mentioned to me that right before this interview, you were interviewing Dr. Lamberg, which is one of the great clinicians that I believe in his science and understanding. He was talking to you about non-obstructive means and reasons or factors that create a sleep apnea, right? In my office, I'm treating obstructive sleep apnea. I'm not treating upper airway of the patient. Do you know, Nicole, I have treated patients with MMA surgery. And after MMA surgery, still their sleep apnea was there. From 19 AHI, I dropped it to 17 AHI because it was not just obstruction, it's other physiological factors, nutrition, diet, leaky gut syndrome. So all those things can contribute, or low arousal threshold,
That's
or
exactly.
so those are
That's
the things that we need to understand.
That's what Dr. Lamberg and I were just talking about. So in the 2 episodes before this one, it's that as an airway orthodontist, you're working on structure and the anatomical component, the anatomy, but there's also non-anatomical components in most cases with sleep disordered breathing as well. So everything needs to be attended to.
Sure. And then the issue is that, yeah, for airway orthodontic, you expand to a 3 millimeter and 5 millimeter and say that, well, you know what, we are treating airway. Great. It's a good mechanism. At least you're not constricting. But is it enough to treat a sleep apnea? Well, I have failed so much. When I was not able to expand enough, I expanded and I didn't get the result that I expected. So it means that we need to expand the palate meaningfully, because expansion of the palate is not always equivalent to one to expansion of nasal cavity. So it means that you expand the teeth 10 millimeter. Palate is not going to be expanded 10 millimeter. It's going to be expanded maybe 2/3 or half of that. And the same with the nasal cavity. You expand the molar to molar 10 millimeter. There is no way that nasal cavity is going to be expanded 10 millimeter. Is the ratio, and the ratio is not 1:1. So based on our best experience, when we expanded the palate of the patient 10 millimeter wider, yes, the nasal cavity probably opened up for 5 millimeter that is meaningfully enough for treatment of a sleep apnea, right? Meaning that drop the AHI under 5 and cure it. Maybe in my hand doesn't work, but that's the way that we have been successful. But that comes another question. So Nicole, you have a jar and you have a lid, and they match. If you are going to open this jar 10 millimeter, what are you going to do this lid, mandible? If they don't match and you don't expand the mandible, the opening of this jar cannot be open 10 millimeter, which is meaningful enough to treat a sleep apnea. Maybe you can say that, yeah, it's going to improve the airway, but I'm treating a sleep apnea. In my hands, in order to treat a sleep apnea, I need to correct every passage of the air from nostrils to the hyoid bone. That's why American Association of Orthodontics white paper. In order to treat a sleep apnea, we are not working on the cranium of the patient. We are working on the anatomy that starts from the nares all the way down to the hyoid bone. So it means that expansion of the palate is fine, but then we need to have means to expand the back of the palate, behind the tongue, below the tongue, and all the way up to the hyoid bone. So in this case, is necessary, or do we need to expand the mandible or not? Is it just uprighting the teeth is going to be enough to match the expansion of the upper? It is fine. If you expand the upper jaw for 5 millimeter, you can upright the lower teeth about 4 or 5 millimeter and match it. But if you expand them beyond that, you're going to be beyond the alveolar bone in the lower one. And guess what? You're going to push the teeth into buccinator muscles. And those muscles, they are not going to be forgiving. They are going to push it back. Teeth are going to upright, and that is going to compromise the relationship of upper and lower. So based on my experience, and expanding the base of the mandible, which is going to push the attachments for the buccinator muscle farther out and create enough room for the teeth to be bodily expanded, that is going to make the suprahyoid muscles and platysma, all the muscles, and they are going to be kind of stretched. That is lifting the tongue a little bit up, and that is going to create more room for the tongue in the palate, in the floor of the mouth, so tongue comes forward and open up the airway. Now, of course, it's not easy technique, and it is. I'm not the one that talked about what we call distraction of the mandible first. In early 1990s, Dr. Guerrero is the one that came up with the idea of expanding the mandible. Mandibular symphysial distraction osteogenesis. So it started expanding the mandible, and it was for a while they got good result, because when they did enough of those, they realized that the technology that they were doing it was distracting the condyles of the patient. And this patient that they expanded the mandible, well, after a while, they get a lot of TMJ symptoms. Because, Nicole, if you look at the mandible and you just dislocate it or this way, or, so what happens is that the condyles, they are very, very tight structures on each side, and you are going to distract the condyles. The change that we did to this, what we call understanding, is making the mechanism that when the jaws are going to be distracted in the middle, it is going to maintain the condyles in the socket of the joint, and just in the front is going to distract it. So, and am I the only one is doing it? No. Now there are clinicians that they realize that is important. Now, there is a difference between orthodontists and surgeons looking at this problem. When I go and talk about distraction osteogenesis to surgeons, maxillofacial surgeon, Nicole, the surgeon, they ask me, we are wondering why not every orthodontist, they learn how to do the distraction of the mandible. Because for surgeon, it's so easy. Just make a cut here and then just expand the mandible wider. Why orthodontists are so afraid of it, which is not as easy. Yes, we need to be careful about distracting the condyles out of the socket, but then surgeons, they believe that this is a good technology. It's simple surgery with maximizing the airway of the patient. And as a result of that, there are surgeons in United States, which I know, Dr. Movahed, and started doing this. And Dr. Kevin Coppelson, he in interview with Ron at JawHack said that he has started using this. They haven't done too many of this, but they see good results on the cases that they were successful on opening the airway and resolving, avoiding the extractions. So in our system has been very, very successful for treatment of sleep apnea, avoiding extractions. And we don't call it MSDO. We don't call it mandibular symphysial distraction osteogenesis, because we notice in some cases that, for example, the condyle is so significantly damaged, chin of the patient shifted to, for example, that side. If we make the cut off center, not between teeth number 24 and unit 25, just maybe 23 and 24, we can push the chin of the patient in the back to the midline of the patient. And so then if we call it mandibular symphysial distraction osteogenesis, symphysis is this suture that close at age 1 in children. We call it the same name. So that's why we call it distraction, mandibular expansion surgery.
Okay. And is that called DAME? Is that the abbreviation?
That's right. Distraction assisted mandibular expansion. Yes.
Okay, so DAME. So MSDO and DAME are both surgical techniques to expand the mandible. And in an adult, MSDO is going through the midline of the mandible, and DAME could be shifted to either side. It doesn't have to be in the midline. And so let's talk about this. So a lot of children who are getting palatal expansion with RPE, the lower jaw is not being attended to. And a lot of people say, well, you can't expand the lower jaw, which I understand the bone is fused. But I want to ask you about in children, what should be done? How important is it to do something to expand the mandible in terms of like uprighting teeth? That's one question. And then also for adults, when an adult gets a MARPE, the teeth will be uprighted, just so everybody understands, with like Invisalign or an orthodontic technique to make the teeth align, because when you're only expanding the upper jaw, the teeth have already been compensating to be an occlusion prior to that. So we need to upright the teeth so they go back to a correct bite. But you're saying there are techniques like DAME to expand the mandible, which will allow more expansion on the maxilla. Is that the purpose of that?
Exactly.
Okay.
So it
Can
means
you
that
address the child part first?
So the thing is that if the mandible is not expanded, because if we expanding the mandible, 10 millimeter or 4 5 millimeter, now we are capable to expanding the maxilla meaningfully 5 6 7 8 9 10 millimeter. When we are working, the mandible is going to be expanded the same amount, versus if you don't expand the mandible, the uprighting the lower teeth is just 3 or 4 millimeter is not going to make it enough to treat, again, sleep apnea of the patient. Airway is different. Maybe you enlarge the airway, but that maybe is not good enough to treat the sleep apnea. But at the same time, for child, especially up to age 12, 13, 14, still are very, very plastic. meaning that the dental alveolar, as long as we don't extremely, you cannot expand 10 millimeter dental alveolar in the arch of the lower, maybe 5, 6, 7 millimeter meaningfully expanding dental alveolar in the child is not going to expand the symphysial area when you do the expansion, because this joint, science shows that at age 1 or 2 is fused. So when we do the expanders or Invisalign or the dental expanders in the kids up to age 12, 13, 14, it's fine. But not then when we are talking about scientific approach. Then after that, maybe age 14, 15, this teeth or the dental alveolar bone is not as forgiving. And if you do that, there is a chance that you push the teeth so far out that the teeth are not, the bones are not going to be regenerated, and the teeth are going to push out. So up to age 12, 13, based on my experience at what data today scientifically shows, up to age 12, 13, uprighting the teeth and expanding them dentally, maybe about 4, 5, 6 millimeter is fine. So when we do this type of expansion, rapid palatal expansion in the kid up to age 12, 13, so expanding the maxilla about 6, 7, 8 millimeter and making the lower, dentally up to 6, 7 millimeter wider, it can be stable. The jaws, they can adapt to it. But now we have the new mechanism, MARPs.
Ask one more thing about the child before we go to the MARPI for the adult. So what about a lot of children who are just getting upper expansion, so just getting RPE? I see a lot of patients who have nothing on the lower jaw. What is the importance in a child under the age of 12 to do something on the lower jaw, and what would be done to upright teeth? You said Invisalign, or what types of appliances?
So there are some other appliances and that there are dental expanders or expanders that they are going to put in the lower arch of the patient and dentally expand it. There are so many mechanisms on that. So expanding the upper jaw again is like expanding the opening of the jar, but the lower teeth, which is the lid of the jar, is going to be stay the same. So maybe they expand it, but eventually when they move it around and wiggle it around to match the lower one, they bring that back and to match the lower one. How much is meaningful expansion they get? Some. Because when they expand, if they expand the palate and still wiggle the teeth and bring it to the lower, it does some good to the expansion of the tongue space, but how effective it is, that's the question.
Okay, because when you're expanding the bone, you're doing that skeletal expansion on the upper in a child, which is pretty easy to do because the suture's not fused and you're using that RPE affixed to the teeth. You're expanding the skeletal part, but then when you go to align the teeth, you're losing some of that overall expansion if you're not uprighting the lower teeth, because when the palate's narrow, the teeth have compensated to meet. So would you say nearly all cases of palate expansion in a child should be accompanied by dental expansion on the lower jaw in a child? Is it ever sufficient just do RPE on the upper?
There's different opinions, and I'm sure that different clinicians, they have different opinions, but in my hands and the ones that they have the same train of thought as me, if you're expanding the palate of the patient, you need to have the means to expand the dental alveolary, the lower arch, so they can match and the expansion stays meaningful and effective.
That makes perfect sense. And then moving on to the adults with the MARPI, I know when I had MSC, I had a crossbite from that upper expanding really wide before the lower was addressed, because my lower teeth were tipped in to meet my narrow palate, right? And so then they upright the teeth for me with Invisalign, but you do lose some of that expansion because, right, teeth are uprighted. And I did actually feel that. So I think my upper teeth were sort of flared out. And when they made everything upright, I think it felt like my lower jaw got pushed back a little bit. Everything got reversed a tad bit. So I definitely felt like I lost some of that expansion with the uprighting of the teeth. So let's talk about an adult, your thoughts on that mandibular portion. And I know a lot of people want to go with MARPI because they don't want a surgery. But this dame on the lower jaw. That's surgical, right? Can you talk about that whole approach? And why don't we just do MMA if we're going to do surgery? So go into detail about that.
So you mentioned it that, I brought it up that the white paper by American Association of Orthodontics, they recognize for treatment of sleep apnea, the obstruction can be from all nostrils all the way to the hyoid bone. So we need to have means to expand nasal cavity behind the palate, behind the tongue, below the tongue. So, and again, I'm repeating this expansion of the mandible is going to do that. It's not just expansion of the mandible with Dane. You know that there are some SFOT, surgically facilitated mandibular, dentoalveolar expansion of the mandible. So it means that if they do the corticotomies in the lower and pack some bone, they can upright the teeth, but they can move it a little bit out. Not 10 millimeter, but they can do it about 3 or 4 millimeter wider. And that's another means that orthodontists, they have been using it in conjunction with the MARPI expansion on top. So again, is for the stability of the expansion of the upper and get some more expansion in the lower. But that comparing it, even the Dane, we know on the patient that we have done Dane and in conjunction with the, and we call it Dane. So it means that distraction, nasomaxillary expansion. The way that we do it, we really expand the nasal cavity wide. Is we call it distraction assisted nasomaxillary, is not just what is called MARPI. So now we get 10 millimeter expansion or 6, 7, 8, up to 10 millimeter, not more than that. That is going to open the airway, the jaws wider. So you have room inside the mouth. It makes the lower jaw a little bit longer. The way that we expand the lower jaw wider, it makes the lower jaw a little bit wider, just 3 or 4 millimeter, all right? But that's meaningful. So that 4 millimeter expansion of the lower jaw bring the lower jaw a little bit forward, all right? So when we started doing we have done over 200 of, dames now, significant number of them, over close to 150 of them successfully started more than 20 years ago. Successfully, those cases are very, very successful, stable. But at the same time, we noticed that when we expand the mandible, the way that we do it, the mandible gets longer. So, Nicole, that's the issue. The lower teeth, now they are going to be edge to edge to the upper one, right? So for a while, we did these cases with the MMA, and we were doing the dame with the MMA. MMA is front to back, is very, very profound, because MMA is doing not only front to back, but is counterclockwise. So I showed you this case. So let's look at this. So this is one form of MMA. We call it counterclockwise rotation. Again, this is the inverted L type of expansion, but you see that during the expansion is kind of counterclockwise, the rotation of the mandible, and that brings the base of tongue significantly forward, right? So the expansion of the mandible, or MARPI, or we call it Dane, does not have the meaningful expansion like this, right? But this is very aggressive surgery, Nicole. It means that after surgery, so they need to look at this size of this, in what we call the metal plate that is there. Look at the plates that are in the back. But we reserve these for patients that they have meaningful severity of a sleep apnea, or like this patient, severe deformity of the face, all right? So if patient comes with the right face, not the left face, and their sleep apnea is not very severe, should we, for every case, should we go to MMA? That's the question mark. How bad is the sleep apnea? How bad is the face looking? How much improvement we need to, is the bite is correctable? Do we need to bring the lower jaw more forward to match the upper? Those are the questions that deciding between MMA or expansion of upper and lower jaw plays a role. Severity of sleep apnea. how much we need to bring the jaw forward to treat the face and airway. And
Okay.
also, I had a patient yesterday that I'm talking to him, and I can mention Daryl talking about that getting the expansion because his fear is he doesn't want to have these, metals in his jaw for the rest of his life. And he doesn't want to jump into the MMA. He'd rather do the expansion first, see how much airways improves, how much his face is going to improve. And if the sleep apnea is not answered, then we have another option to go to MMA. So it
Okay.
gives us one more option for patients that they don't have severe sleep apnea, significant deformity of the face and bite can be corrected, with those minimally invasive procedures.
That makes perfect sense. It's almost like a middleman between just a MARPE, or then you have MARPE Dame, and then the next extreme would be MMA. So this is getting more expansion typically than MARPE. What are you doing in the Dame procedure? Where are the cuts, and are there plates put in, or does it just the bone grows back and there's no metal?
Okay. There is another concept called MAIN, microimplant assisted nasomaxillary expansion. MAIN, MANE, microimplant assisted nasomaxillary expansion. It is doing the MARPE with no surgery or anything on top, like this patient that she's about 17. She's published in the book. Her case is published in the book, a small airway, and she has the AHI of about 12, 13, and we stabilize her joint. She had TMJ problem, pain, discomfort, and this appliance actually helped her to breathe better and manage the sleep apnea. But at the same time, she wanted to do something permanently. So we use this technique, MAIN, microimplant assisted nasomaxillary expansion, which is upper and lower. Upper is going to be just microimplants with no surgery. That's what MAIN is, no surgery. On top, because the mid palatal suture still is more giving and opened up. And then in the lower part, they did the surgery. Dr. Roshan, surgeon, in matter of 15 minutes, Nicole goes from inside the lip, open the joint, which is right between teeth number 20, 25 in 15 minutes. And then we can expand the upper and lower jaw simultaneously 5, 6, 7, 8, 9, 10, depending on the sleep apnea, depending on the crowding that the patient has, and that creates, again, tongue space.
Lower expansion that they do in the main, is it the Dame expansion on the lower?
Dame expansion in the lower, main on top. Main on top and dame in the bottom. Yes,
Got it. Lots of acronyms, but I got it.
that's right. And then she's wearing the appliance. So that's the thing that is important, Nicole. At this stage, that patient has a sleep apnea, we give the patient so many instruments in their mouth. I mean, the expander on top, expander on the bottom, their severity of a sleep apnea is going to be increased. Unless we give the patient CPAP, at this point, patient is going to get more sleepy, sleep apnea gets worse. That's why we developed the APNO TX that they are going to wear it before starting this stage during the preparation, because during the preparation with Invisalign, we need to create a space between teeth number 24 and 25. So when the surgery is doing the cut, surgeon doing the cut, don't damage the roots of 24, 25. So after this stage takes about 3 to 5 months. Then when they have the appliances, that makes the airway worse. And also at this stage, Nicole, the bite is so unstable. They don't have a stable bite. They clinch and grind because the sleep apnea is worse. So bruxism is worse. So the appliance, the APNO TX now every night is going to be used to stabilize the joints, reduce the chance of damage to the joints, reduce the damage to the appliance because of clinching and grinding, and manage the sleep apnea. We notice, and we are going for period of time, we decided to bring the cost down, not letting the patient not using the APNO TX and not going to that option because of expense. And Nicole, we noticed that majority of patients that they didn't have the APNO TX, they ground and clean so much that they damaged their appliances. The more breakage we experience, they broke the expanders. So we stop allowing that. So if they are going to go to Dame, Main, or Dane, they need to have the APNO TX as part of the appliance, and they're going to be much more comfortable, not getting sleepy, clinching, or grinding.
Can I ask you about this APNO TX? So the APNO TX is something you developed. Would you consider it like oral appliance therapy, or is it kind of a different degree? Because it sounds like it's like oral appliance for sleep apnea, so sort of like a mandibular advancement device, also like a night guard, also a splint for TMJ. It seems like it does a variety of things. So what would you consider that a APNO TX that you developed?
As you said, is a multi-purpose appliance. Is the appliance that, again, as you said, is for the TMJ pain and discomfort, is the for bruxism, anti-snoring, managing the sleep apnea, and it can be used with braces, Invisalign, as you see patient is wearing right now, upper expander. In the next picture, is wearing the upper expander, like lower Invisalign. So it can be used upper braces, lower Invisalign, lower braces, upper Invisalign, or expanders. And then later patient goes to the surgery and they have surgical wires, it still can be used in that period of time. Very, very versatile appliance.
Okay. And would you consider it a temporary appliance as someone's going through their orthodontic treatment, or well, we should their telodontic treatment or telegnathic treatment, and then after they're done with this APNO TX, or is this something someone might wear for the rest of their life when they're sleeping?
Well, it is a temporary appliance. It is a band-aid appliance that they wear it at nighttime only for those purposes as I mentioned. And when they wear it, it's working. When they don't wear it, it doesn't expand the upper jaw. It doesn't expand the maxilla. It follows the expansion that is done either dentally with Invisalign or skeletally with expanders or MARPI. It doesn't expand the jaws. And then hopefully after the expansion is done, the sleep apnea is cured. They don't need it anymore. Now,
That makes sense. Okay.
yeah, so they're done. So
It kind
they
of is following their treatment. It's not like popping on a mandibular advancement device or a night guard for bruxism that's helping manage or band-aid symptoms. It's just helping the patient get through their telodontic, telegnathic treatment. And then once their sleep apnea is cured, then they stop wearing that.
That's right. They don't need to
Okay.
wear it. But at the same time, so we have a great success. Majority they respond to this treatment. Hopefully, expansion or maybe is necessary MMA cure their sleep apnea. Or we have so many A to Z plan. Success rate is over 90.3%, but not always the patient want to go to the MMA. So they do the expansion, the severity of sleep apnea from very, very severe, just imagine from 87 AHI drops to 7, 8, 10. But still, they have some minor issues that make them sleepy, tired. So they say that I don't want to go to MMA. So I'm going to use the APNO TX at nighttime, managing my sleep apnea for rest of my life. Every 4 or 5 years, they need to change it, and they use it as oral sleep appliance.
Okay, so it could be used as an oral appliance for someone for nighttime use the rest of their life, and it doesn't change the bite. Can we talk about that? And then also, it looks really bulky. So, are you going to have someone use lip tape? How do they get the lips closed with that?
Depending on the structure of the face, and Nicole, if the if a patient has short face and we open it up, is not going to be so hard for bringing the lips together. But patients that they have like high angle cases and they have open bite and they have hard time to bring the lip together, right? Guess what? That struggle of bringing the lips together, tongue and everything else, is a myofunctional therapy for them. So the
It's right.
appliance and struggle that they bring the lips together is going to exercise the muscles. So in a way, is a myofunctional therapy for patients. Also, is an instrument for myofunctional, exercises. But yeah, the mouth taping is going to help so they don't drool and they maintain it in the mouth till they get used to it.
Okay. And this sounds like it's one of the only oral appliance therapies. You're saying that it doesn't impact the bite. If it's just somebody wearing it at night to manage their sleep apnea, do they have to do exercise in the morning to put the lower jaw back, or how does that work?
Yes, it does. The thing is that based on the research that again done by American Association of Orthodontics, based on 10,000 cases that they did on oral appliances and the mechanism of the way that it works, they noticed that all of them out there, they have a headgear effect. They anchor the upper teeth or one way or another to hold the lower jaw by means of the anchoring to the lower teeth. That's why change of the bite, reducing the overjet, developing over open bite in the back is very, very significant. But the way that the APNO TX works, there is nothing hanging against or is sitting on the upper jaw, but is nothing holding the lower jaw. There is a system that is called mechanosensory activation. As soon as the bite comes together, it stimulates the lower jaw. So the muscles of activation of the lower jaw bring the jaw forward, and there is nothing hooked to the lower teeth, so they change the bite. But that's the majority of the change of the bite created by oral appliances. There is another thing that can change the position of the lower jaw, meaning when the jaw is forward, if you remember anatomy, there is a shunt behind the condyle, with that shunt is going to engorge with the fluid when the jaw is forward. So there is no empty space behind the condyle. When the jaw is the whole night forward, that engorgement of the fluid into that shunt and the condyle cannot go back. So every morning we need to reposition the mandible and squeeze this fluid out. But at the same time, there is another thing that it does is the myofascial adjustment. The myofascial gets shorter when the mandible is forward. The lateral pterygoids, when they're in that position for 7 hours every night, continuously for long term, especially if the mandible needs to come forward a lot for severe sleep apnea, can make the length of the lateral pterygoids shorter, especially the lower belly. So then that reposition the mandible forward. So every morning we need to reset the myofascial tone, stretch them back to original, squeeze out the fluid out of the joint, and that normalize the bite. So it still is important with APNO TX and APNO Dent. Every morning reset with the morning repositioner, but what it does not do is change of the bite. It does not change the bite. That's the main category of making the bite of the patient so change that they're going to now create some TMJ issues and permanent change bite. There is one thing that APNO TX does that is tremendous, is creating pseudo disc, meaning that is very, very capable that if the disc is damaged, regenerate retrodiscal tissue, where is the behind the disc, thicken it, and make it what is called pseudodisc. Is powerful. In children, it can lengthen the lower jaw. Even in adults, it can lengthen the lower jaw, not by adding to the condyle necessarily, but adding to the thickness of retrodiscal tissue and make it pseudodisc. That is going to improve 3 or 4 or 5 millimeter overjet, minimize it and improve it. But that should be under control. So if we want it, we can take advantage of it and make the lower jaw go forward under the maxilla to improve the bite. But at the same time, in the case that is class 1 and we have tight occlusion, every morning we need to control the development of pseudodisc so it's not tremendous and is under control. That's why morning positioner is important.
Okay, and then for the APNO TX, you're saying the upper and lower jaws aren't affixed to each other? They're
The
not being
lower
held.
jaw is completely loose and moving. So it means that APNO TX on top, APNO TX is a loose appliance between upper and lower. Nothing is holding it against the upper, nothing is holding it against. It's
How,
contrary to it's just the jaws. It
how
is
does it
like
prevent
a
the lower
knife.
jaw from falling back when the person's sleeping if the mouth opens wide?
So for that, I need to go to another presentation. So let's the slide that I was going to show you, on the main dame. So this is the result of expansion of the upper jaw, expansion of the lower jaw, you know, and then after during the expansion period, patient has a still upper expander, lower Invisalign. So it continues. This is right after removing the upper expander. Then we go to Invisalign, and this case patient doesn't need the APNO TX anymore. So now this is her jaw after expansion, and you see that the nasal cavity expanded, and that's what it does. So it means that, Nicole, the question that you ask, if we do expansion of the maxilla without the mandible, how much can we expand the maxilla alone? If we expand the mandible, we can double the expansion of maxilla. So for improvement of a sleep apnea, not just airway. So if we use the expansion of the upper jaw, we can get 5 millimeter. But we expand the mandible, now we can add 10 millimeter expansion on top, 10 millimeter expansion and in the mandible, and that really the upper airway, in nasal cavity, behind palate, behind tongue, and below the tongue. So
That
that,
makes
yeah, this is
sense. So if you expand the mandible, you can get 2 times as much expansion in general on the maxilla as well. Now, is that only through the surgical technique of Dame, or is that also a similar idea with a child when we're uprighting teeth on the lower when they're in RPE?
Well, and by the way, this is after surgery. You see that the area is completely healed. You see this before
Yes, yes.
and after. See the bone completely healed. And here is sleep apnea, that originally was 11.4 and dropped to 3.8 under 5 is cured. So now the for child is different, because for child we are just expanding the dentoalveolar and we are not expanding the skeletal. So the impact of the expanding the mandible dentoalveolar of the kid is not as effective as Dame, but at the same time we are not expanding. The youngest patient that we expanded right now is 11 years old. That's the first
With
time.
Dame, you're talking about? Oh,
Yes.
wow.
Yeah, and I can show you a case, if time allows. So the first expansion we did over 20 years ago. Let's go back to that. I show you.
Okay, so the youngest patient that you've done, Dame, the surgical expansion on the mandible was 11 years old. And yeah, I want to talk about why you chose to do a surgical technique on the 11-year-old
So,
and who's a candidate for Dame and who is definitely not a candidate.
so if you look at this, is case to case is different. So the palate is so narrow,
Yep, very narrow, lots of crowding.
lots of crowding,
And this
and
is, how old is this child?
11 years old.
This is the 11-year-old. Okay, wow.
Right? So that's the thing, that either extraction or resume with the dame in the lower, and what we call, it was just the rapid palatal expansion on top, no screws or anything like that. But you see that this patient, this is the, again, expanding the mandible, maximize the expansion of the upper during the expansion. This is after. Makes sense? Look at the
Yeah,
airway before and look
wow.
at the airway after.
And can I see the pictures of his face again after?
Yeah. Now, the thing is that still this patient, the way that we did it 20 years ago, we could do much better if we did it today. Still
Mhm.
patient has bimoxillary dental alveolar protrusion, but we need to consider that this is Asian heritage patient. So if we did it today, still we could expand it more effectively to bring the teeth back and make protrusion of his lips better. But at the time, 20 years ago, this was the best we thought that this is the best we can do. But today,
How
it's more
it could
much
be done.
more effective. Yes.
How long was that procedure, that pre and post, these pictures? Because he looks so much more mature and older.
Just about 3 or 4 years. But
Okay.
remember, that first one was right away, and then we waited a little bit before we put the appliances on. So it was the picture that I showed you right in the beginning. This one, there was a year before we started expanding. All right.
Okay.
At the same time, between these to this stage, this phase is about 3 or 4 years post orthodontic.
Okay. So what exactly is going on in Dame? Where are the cuts? Who does it? Does the orthodontist or is this done by an oral surgeon?
It is an interdisciplinary approach that a surgeon does the cut because it's the bony cut. It's not the just do the what we call the piezotomy. And one of the questions that you are going to have is, have we ever failed in Dame? And we failed on one case, Nicole. We are training surgeons, and one of the surgeons that we started wanted to do the piezotomy, and I was not very keen about the using piezotomy here. It's different on the roof of the mouth versus symphysial area, and he insisted that he does everything with piezotomy, and he used the piezotomy. In was a young adult, 20 years old. Nicole, when we started expanding the mandible, everything just fell apart with the piezotomy. So at this point, my only failure that I stop and say that don't do anything was piezotomy done in the symphysial. Maybe he didn't do it right, but it was not a good experience doing the piezotomy in the symphysial area. So we never done it before. We do the piezotomy on the roof of the mouth, on the palatal area, but not in this area anymore.
Okay.
It doesn't work very well. That is our only case that we said stop, no more expansion.
Okay. And the youngest is 11 years old. And then what's the oldest?
75.
Okay.
So
And
75 years old that he needed to have the MMA surgery later. So we did that because he had a lot of crowding, avoiding the extraction. We expanded lower jaw, and then later he had the MMA to cure his sleep apnea.
and sometimes don't they want to extract for MMA so everything can be brought forward more? But does this technique avoid that?
Yes, that's right. I just recently had a patient that traveling from Canada, and unfortunately, exactly what you said, they wanted to advance the mandible, but he had class one, so they extracted his first bicuspid to bring the incisors back to create enough overjet to advance the mandible. But when we do the expansion, we don't need to extract anything because when we expand, the lower teeth now they have room to come back, and then we can maximize the advancement of the lower jaw without
Okay.
extracting.
So this almost sounds like doing on the upper a MARPE before MMA, where some MMAs don't involve that type of transverse expansion. But now we're kind of
That's
doing the same concept on the lower, so you can get more expansion, probably more tightness, like you said, on the hyoid bone area, all around there. Okay, that's interesting. That's making sense. So is the dame just a cut along the bottom and it's just a single cut?
that's right.
What kind of appliance is there after the procedure?
So the surgery is about 15 minutes, and then we are going to wait about the technique in the lower one is if you go very slow, it can fuse. So it is different from the roof of the mouth. So you can go fast. So minimum is going to be one turn, sometimes 4 turns a day in order to avoid the fusing of the lower, because if it fuse, then we cannot expand it. Then after that, it becomes what we call dental expansion.
Okay, so there's an appliance that they're gonna turn a key like a jack screw on the lower,
That's
just
right.
like you might an RPE or MARPE in an upper. Okay, and so it's a single cut. There's a screw expanding, then it's osteogenesis. The bone is gonna fill in. All right, so that is Dame. This is
That's
interesting. Are other orthodontists doing this technique? How many are people aware of this? If I talk to an orthodontist about this, would they know what this is?
So the thing is that I mentioned to you, there are surgeons that Dr. Movahed and Dr. Coppelson, they started doing this, but orthodontists that are comfortable to this, well, we are willing to teach them, but at the same time, there is a problem because technique and the concept is FDA registered. So it means that we can use it. Versus APNO TX and APNO Dent, they are FDA cleared. We can teach it to other clinicians, but at this point, in order to make the DAME and something that we can teach it to other clinicians and they can use it in order to commercialize it or anything like that, we need to have the FDA clearance, which is going to cost about another 100, maybe more $1,000. So we are in the process. APNOMED, that is the IP holder of these techniques, it is getting funded, and hopefully with enough funding, we are going to have the FDA clearance for DAME, and the other procedure is called MAPI, so we can teach it to other clinicians.
Okay. I assume you would never do DAME without an accompanying MARPI, right? You would never have a lower
Actually,
expansion.
is not
Huh?
MARPI. It is okay. Let's talk about that. You asked me another question about the lower jaw. The APNO TX is not attached. It
Oh,
is like
yes.
a night guard. Just imagine is wearing a night guard. You bite down, the lower jaw comes against the night guard and it stop there, and that holds the against the upper. The concept of the APNO TX or APNO Den is the same. When it works like a night guard, when patient bites down, it's holding the appliance between upper and lower teeth. Is a floating appliance, nothing attached to upper, nothing attached to the lower.
So isn't it possible though, when the patient falls asleep, the mouth is open, that lower jaw could fall back because the upper and lower aren't held together?
Very, very rarely. We
Okay.
had just one or two cases, again, amongst thousands that we have done, and one or two, and then in that case, either mouth taping or they
Okay.
use the chin wrap around their head to hold it. But it's very, very rare that happens.
Okay. Chin strap or mouth taping is going to help support that lower jaw if needed, if the patient's finding their lower jaw is falling back. Okay.
Yeah.
That's great.
There is an issue with Dane. So I'm going to share my screen again.
Okay. At the end, let's make sure you let us know who's a good candidate for DAME and who might not be a candidate at all. Okay.
So now the thing is that, Nicole, when we started doing Dane, we were using always with MMA. So all cases that they are class 2, because Dame is making the lower jaw about 3, maximum 4 millimeter longer. So if by any chance patient is just having MARPI, all right, there is a chance that patient ends up with edge to edge or crossbite in front. So in order to do Dane without what is called MMA, so we developed a new technology. So this is a patient that upper and lower jaw is small and is a candidate for the MMA surgery, but doesn't want to do MMA surgery. So this is the initial shape or design of the APNO TX. Now has advanced so much, but this he gets. We can do the Dame with braces these days with Invisalign, and then this is another technique. This is called MAPE. Is a micro implant assisted protraction expansion surgery. In kids, we don't need to do any surgery, just 4 or 6 micro implants. But in adults, young adults even, there is a expansion procedure which is like a dome or like Dane, but also bone augmentation is like a SFOT and brings the teeth maximum 4 millimeter forward. So because and during this stage they are going to wear some fake teeth so the space doesn't show, but the advantage of it is that making the upper teeth coming forward, make the palate wider, nasal cavity wider, and is going to be coordinated with the lower jaw. So you can see the lower jaw gets longer. So we need to bring the upper teeth forward and is skeletal expansion, then to alveolar advancement of maximum 3 or 4 millimeter. Now, patient, if they use the face mask and they're young enough, we can maximize the movement of the maxilla forward. So it's a great procedure. It is what we call mini MMA. So, Nicole, this is not MMA. This is called mini MMA.
Okay. Who would definitely not be a candidate for doing these types of expansions on the lower? Is there any contraindications?
No, because now even with patients that they don't have a lot of crowding, we have developed the techniques that we can, they doing the dame, but the only ones that they have get contraindication if they have receding, significant receding gum in the lower anterior area, we don't recommend it unless they do the gum graft first, and then after gum graft you can do this. So practically there is no contraindication. The only thing recession, but we can take care of the recession with gum graft, then proceed with day.
Okay. So I want to know, do you think all orthodontists should be screening for sleep disordered breathing? And if so, what types of questions should they ask, or what might they be looking for if maybe an orthodontist is not on board with this yet?
So one of the questions that comes to mind, Nicole, is that what is the future of orthodontics, the way that I see it? All right. The way that I see orthodontic in future is going to have a branch of orthodontics and dentistry that still they want to work on the alignment of the teeth, cosmetic. There is nothing wrong with it. Nothing wrong with it. Still do everything cosmetically and functionally for function of the jaws and bite. But then there are going to be group that they become medical as part of the medical team to treat sleep apnea. Those groups, like me, they are going to be part of the team that is going to have surgeon, ENT, myofunctional therapists, nutritionists. But this group of orthodontists, they are going to be equipped with the mechanism like teledontics, telegnathics, to expand their airway and enhance the airway and treat maxillofacial deformities, temporomandibular joint disorders, especially sleep apnea. And Nicole, I promise you, when we combine MMA with the expansion of the jaws or as addition ENT surgeries, we have A to Z plan for treatment of sleep apnea. Even the most severe 175 AHI can be addressed and managed properly in majority. Not every case. We have still 9 to 10% failure because of gain weight or weight, but success is over 90.3% for curing the sleep apnea. Telodontics and telegnathics has kind of connected that bridge between dental, and that's the future of orthodontics the way that I see it. Dentists and orthodontists in airway and sleep apnea, and stay with cosmetic only.
Really interesting. So kind of two branching off fields. I like that. I think that's an interesting way to look at it. And people can kind of go into what their specialty areas, what their interest is. And that's an interesting way. And I know the people, as the people get more educated on airway and health impacts, which profession are they going to start seeking more treatment from? So that'll be interesting. People might start really recognizing that the cosmetic aspect is maybe secondary to the telodontic, telegnathic, the airway component, and they work together. So this is great. I really, really appreciate all your time. This has been a lot of education. And any other words for our audience that you might have?
This is very, very exciting. And one of my mentors and friends, Dr. Bill Harrell, remember we were in the working with the CATS group. Again, Bill is such an amazing, amazing orthodontist and clinician and educator. He asked me to give about 1 hour of, sharing my experience with his orthodontic program, at University of Alabama. And then I told residents that what an exciting era of orthodontics. That you have now can pass this bridge. And when you are doing these orthodontics to your patients, you want to call it orthotropic or telegnatic or teledontics, you have the capability not only that beautifying the smile and enhancing the smile of the patient, but adding decades of healthy life to them. All right? Take the opportunity, appreciate this moment because the future is so, so bright. We are saving lives, Nicole. You with your myofunctional therapy, me as orthodontist, dentist, we can save millions of lives. That's the
It's
future.
so beautiful. Thank you so much. And you showed a picture of a baby in the beginning when you were talking about the aha moment you had, and we didn't.
Let's finish with that case.
Let's do that.
Yes.
We can't forget. We can't leave that out because
Yeah,
I really want to know, as an orthodontist, how
sure.
how did you get into this aspect of airway? And I know you have a
So
wonderful.
everybody has a paradigm shift and aha moment. This is the picture that in the beginning I showed. So that was the issue, and the issue that the whole teledontics. One of the objectives is how we are going to treat this face that can end up now sleep apnea, the comorbidity of a sleep apnea that is really hurting the patient. I showed you a case to the right. We didn't have time to show the case in the middle, but this is the patient that I showed you here. All right, a small jaw, and look at the palate, how wide it is. Facial asymmetry, the arches are very wide, and smart, active, playing great, doing great in a sport, doing great in education. But suddenly something happened with the wide palate, with wide arches. Started Health started deteriorating. Now kid is diagnosed with ADD, ADHD, acid reflux, metabolic syndrome, high blood pressure, high cholesterol, hypertension, and high blood pressure, and learning disability that didn't have, because now he's developing ADHD symptoms, cannot sleep, cannot remember. The academic performance is getting impacted to the point that the school says that we need to put him special, care or a special education. And so at that point we just removed the tonsils, and later we waited till age 18. The lower jaw was small. Nicole, we didn't do what we call constrictive orthodontic or retractive orthodontic or restrictive orthodontic. We didn't bring his jaw back. We just waited age 18. Contrary to other patients that they extracted and brought his teeth back, we advance the jaw, and that changed the life of this patient, meaning that the learning disability went away. These kids, when they get teased at the school because they call them fatsos and chubby, and they have learning disability, these are the ones that they are high school dropouts. They get teased, and then they decide that education is not for me, goodbye, and they're high school dropout because learning disability that they didn't have, it develops because of a sleep apnea or because of the body disfigurement. So this is a patient, airway improved, and sleep apnea that was severe dropped to under 3.7. Sleep apnea, in my belief system, is a new pandemic impacting over a billion people worldwide. There are millions of undiagnosed patients around the world who need help. Obstructive sleep apnea is a preventable and curable disease with proper technology. So we have created, and we new understanding, we help to develop the technology that I believe that it is working, and we are teaching these in our seminars. We inviting educators like you to share their experience. The technology is good enough to start at 2.5 years old and continue supporting the airway up to age 97 and a half. That's the range that we have been treating with this technology. So another what we call role model for me is Mahatma Gandhi, that I really respect him. And he says, be the change that you wish to see in the world. So this kid is my son, my Ryan. And these are my sunshines in life. And I owe it, Nicole, as the rest of us, to somebody is called Dr. Christian Gimino. I'm so sorry that we lost him. He was an asset, irreplaceable asset. But I really, really thank him. And I'm about to cry again because he helped me to develop this technology that hopefully is going to save millions and maybe billions of lives. Thank you, Nicole.
For sure. Thank you so much, Dr. Yousefi, and all the patients that you've helped. And that aha moment oftentimes comes within our own family, whether it's our children or ourselves. And then we realize the prevalence of this problem, and to have this insight that you have and we have in this airway world is just so profound. Treating breathing, treating sleep is treating the whole person, the whole body in many ways. And we know there's many aspects to this, but it's just beautiful story with your son, how he was in a difficult state when he was younger. And if you didn't know from Dr. Guilleminault and what you know, you might have gone a totally different route. And I know your son, Ryan, he's amazing and he's such a fit guy now and he's doing great. So what a blessing that you were able to identify these things and how many other people you're helping. So again, thank you so much for your time. I know you have another meeting because you're probably going to try to help someone else right now. So thank you for 2 hours of amazingness.
Thanks very much
You're
for
wonderful.
an opportunity.
Thank you so much. Take care.
Bye-bye.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.